Hey guys, this is Sasank Med. Today I'm going to be talking about hyponatremia or decreased sodium levels in the serum. So what is hyponatremia? This is free water excess relative to serum sodium. Remember when you draw blood and measure it and it comes back as hyponatremia, what does that mean? That means that there's decreased sodium in the intravascular space. So there's many reasons for this. I'll get into it, but let's just talk about the symptoms. First of all, most of hyponatremia is asymptomatic. But when it's symptomatic and present with symptoms such as altered mental status, headache, nausea and vomiting, weakness, seizures, signs of increased intracranial pressure, and salt cravings. So you initiate the workup if the serum sodium is less than 130. You get an accurate history and physical. So you want to ask about any symptoms they might be having, anywhere from mild to moderate to severe. So mild symptoms are nausea, headache, fatigue, weakness, and dizziness. Moderate symptoms are confusion, lethargy, difficulty concentrating, gait instability, and vomiting. Severe symptoms are altered mental status, seizures, coma, headache, vomiting, papilledema, respiratory arrest. Next thing you want to do is get a water intake history. You want to get a diet history, how much salt they take on a regular basis, and the urination frequency, whether they have increased urgency, whether they have a backup of fluid in their bladder, overflow incontinence, or any signs of stress incontinence. Any etiology, so any other reasons for SIADH. This includes SIADH in general, but then also do they have any use of diuretics, heart failure, cirrhosis, nephrotic syndrome, any GI losses such as vomiting or diarrhea, any adrenal insufficiency, any excess free water intake. This is called polydipsia, or any postoperative irrigation fluids. So the chronicity, how long has this hyponatremia been present? Is it less than 48 hours or greater than or equal to 48 hours? If so, it's chronic. Any new meds that they start, such as thiazide diuretics, antidepressants, such as SSRIs or TCAs, any anticonvulsants, such as carbamazepine or oxcarbazepine, or antipsychotics, such as clozapine or haloperidol, any chemotherapeutic agents, any desmopressin or oxytocin. Remember, desmopressin is the ADH antagonist. Opioid analgesics, any PPIs, any NSAIDs, any PGI1 inhibitors, any ACE inhibitors, any barbiturates. You want to ask endocrine review of systems questions. This has anything to do with the thyroid, diabetes, adrenal, pituitary, gonadal, parathyroid, or general symptoms. You should look those up and how they present. Their volume status on the physical. So when you do the physical exam and you pinch their extremity, the skin on their extremities or the center of their chest, does their skin crumple or not? If it crumples, especially in elderly patients, they can be fluid dry. So remember, in elderly patients, they do have frail skin. So checking the center of their chest is very accurate because this is the one that's preserved in skin integrity. And you can also check in their infraorbital mucosal membranes of their lower eyelid. You can look underneath it to see if it's dry or moist. You can assess if they have any recent surgery with irrigation. These are usually like with, I forgot what it's called, but the water that doesn't have any solute in. But all right, so studies. So you can order serum BNP, osmolarity, uric acid, either in the serum or urine. This is done sometimes in some hospitals. TSH, AM cortisol, urine analysis, osmolarity, sodium. You can determine if the ADH is present if the urine osmolarity is greater than 100. And remember, when you give IV fluids to someone with hyponatremia, if they have SIADH, sometimes the normal saline will initially increase the serum sodium, but then decrease the serum sodium as sodium is being excreted while the water is retained. For hypovolemia, if normal saline will usually increase the serum sodium. Let me talk about this diagnostic algorithm for a second. You should pause this video and take a screenshot. I'm going to be talking about it a little bit below here. But first thing you do, you check the serum osmolarity. If it's greater than 300, it's hypertonic hyponatremia, aka translocational hyponatremia, because the water translocates from one body compartment to another, from the intracellular space to the extracellular space due to an effective osmotic agent in the plasma. The causes are hyperglycemia, increased osmolar gaps such as mannitol, glycine, sorbitol, and IVIG stabilizers. If the serum osmolarity is around 300, this is isotonic hyponatremia, aka pseudo hyponatremia. This called pseudo because the measured sodium appears low, but the true physiological plasma sodium concentration is normal. It basically happens in conditions with markedly increased lipids or proteins that is driving down the fraction of sodium in the serum. So examples are hyperproteinemia, such as myeloma or IVIG, or lipemia. And then less than 300 serum osmolarity, this is hypotonic hyponatremia. Then you need to check the urine osmolarity. If it's less than 100, then ADH is absent. In this case, the kidney does not have the ability to dilute the urine. The causes are primary polydipsia and decreased solute intake. Primary polydipsia is psychogenic due to the psychiatric illness. Endurance athletes due to increased water intake, or MDMA use. MDMA use makes you dehydrated. Or, one second, does it dehydrate? Yeah, so it can increase the water intake and also decrease sodium intake. This is due to tea and toast and beer potomania. So basically these are the things that can cause you to have hyponatremia with ADH absent behavior. So for primary polydipsia, you restrict the fluids. For decreased solute intake, you slowly introduce the solute and it will correct rapidly at high risk for overcorrection. Just for note, the urine osmolarity cutoffs increases with decreased GFR and severe acute kidney injury and chronic kidney disease. So if the GFR is less than 15, the kidney cannot dilute urine below osmolarity of 200 to 250. All right, so let's go back a step. So if the urine osmolarity is greater than 100, then the ADH is present, and the next step is to check the urine sodium. So if it's less than 30, the renin-angiotensin-aldosterone system is active and the body is sodium avid, so the kidneys are actively retaining sodium. This could be due to low effective arterial blood volume and the ADH is appropriately released. The causes are true hypovolemia. This means that there's decreased total body weight and decreased effective arterial blood volume, or edematous states such as increased total body weight and decreased effective arterial blood volume can be due to third spacing such as pancreatitis or muscular injury, or CHF, cirrhosis, or nephrotic syndrome. What does this mean? So essentially what it's saying is that the body is retaining sodium, but the fluid is going somewhere in the sodium is going somewhere in the body, such as third spacing in different organs, or the body is just losing water due to dehydration or something like that. So the therapy for true hypovolemia is repleting the volume. So there's a high risk for overcorrection. You watch the urine output and you may need DDAVP. And for pancreatitis, you replete the volume. For congestive heart failure and nephrosis, you diurese. For cirrhosis, you treat only if the sodium is less than 120 and fluid restrict. You should correct the hypokalemia and consider Vaptans and 3% sodium chloride only if severe, or I don't know what OLT means. But okay, so let's say that we go back a step. So the urine sodium, after checking the urine osmolarity greater than 100 and urine sodium greater than 30, this is the RAS is inactive. The renin-angiotensin-aldosterone system is inactive, and there's salt wasting. So this means that the kidneys are not retaining sodium and not diluting urine, and the ADH is an inappropriate response. So this could be due to SIADH, due to CNS disease or something wrong with the brain or spinal cord, either due to injury or irritation of the brain, which leads to non-osmotic inappropriate release of ADH from the hypothalamus and posterior pituitary. This could also be due to pain and nausea, any lung infection or cancer due to a paraneoplastic phenomenon. This is basically when there's endocrine secretion of hormones from a portion of your body that's not supposed to be secreting hormones. And then medications that were already listed, or idiopathic causes. Other causes include thiazides, ACE inhibitors, ARBs, or end-stage renal disease, cerebral salt wasting, or adrenal insufficiency, or severe hypothyroidism. The therapy is to treat the underlying cause. So for SIADH, you use the urine osmolarity to guide management. If there's mild hypovolemia, you can do fluid restriction and consider salt tabs, urea, or SGLT2 inhibitors. If the urine osmolarity is 2 times the solute of serum osmolarity, or urine osmolarity is greater than serum osmolarity, then you can check the salt tabs and Lasix 10 to 20 milligrams, and BID or Vaptans or nephroconsult. So the treatment depends on the acuity, severity, and etiology of the hyponatremia. So the rate and goal is to increase the sodium by 4 to 6 milliequivalents per 24 hours to short-term goal greater than or equal to 125. And typically increase the sodium 4 to 6 will alleviate symptoms. Remember, high to low, your brain will blow; low to high, your brain will die. This is just an acronym to help you remember the consequences of correcting sodium. So if you're correcting hypernatremia to normal sodium, too quickly, your brain will blow, meaning there will be cerebral edema, so swelling of the brain. If you correct hyponatremia to normal sodium too fast, then your brain will die, which is osmotic demyelination syndrome. And if there's severe symptomatic hyponatremia that leads to seizures or altered mental status, 3% sodium via 100 milliliters bolus over 10 minutes can help up to 3 times until symptoms resolve or sodium is increased by 5. The patient is severely asymptomatic, sodium less than 120, 3% sodium chloride at the sodium correction rate, usually 15 to 30 milliliters per hour until sodium is greater than or equal to 125. If the sodium is less than 120 and sodium less than 120 is associated with a 6 to 10% in hospital mortality, you can consider a proactive DDAVP clamp and high osmotic demyelination syndrome risk. Mild to moderate correction, so if there's a sodium of 130 to 134 and a sodium from 120 to 129, there's the specific treatment for the etiology. A slow correction may be increased with increased mortality. So overcorrection, this is when sodium increases greater than 8 milliequivalents per liter in 24 hours or greater than 18 in 48 hours. In high osmotic demyelination risk patients, some guidelines say that the change in sodium by 4 to 6 milliequivalents per 24 hours is overcorrection. So osmotic demyelination syndrome typically has a delayed onset that takes 2 to 6 days with dysarthria, dysphagia, paresis, or weakness of the limbs, behavior changes, and altered mental status with locked-in syndrome. You can diagnose with an MRI 4 weeks after the symptom onset. The risk factors is, so if you're starting with a sodium of less than or equal to 110, malnutrition, ethanol use, cirrhosis, hypokalemia, these are the risk factors that will predispose you to overcorrection. Be aware that rapid correction more likely in hypovolemic hyponatremia. Be aware that rapid correction is more likely in hypovolemic hyponatremia and low solute hyponatremia. Monitor for water diuresis post fluids. And you need to consult renal consult for DDAVP clamp. If the sodium trajectory predicts overcorrection, consider the DDAVP clamp. And if needed, add 3% sodium chloride at sodium correction rate already stated. If already overcorrected, urgently lower sodium to within previous goal. Can use D5W 6 milliliters per kilogram for the ideal body weight over 2 hours, and continue with every 2 hours sodium checks until the goal level plus DDAVP clamp. So if concurrent hypokalemia, sodium and potassium freely exchange. So giving 1 milliequivalents of potassium means giving 1 milliequivalents of sodium and can overcorrect with potassium supplementation.